Bonsoir, je m'excuse, je ne parlais pas bien le français, alors je fais ma présentation en anglais. So infection is my disclosure. And of course, septic arthritis is a nightmare for both the patient and the attending surgeon. There is an increasing number of ACL reconstruction in recent years, so the number of infections is not an insignificant number. The incidence is ranging from 0.14 to 2.4. If you think about the septic arthritis after an ACL reconstruction, you have to consider that this is a joint infection, of course, plus a foreign body inside of the knee, considering graft, hardware, everything. So that makes a difference. It's not just an infection, but we have a foreign body. We were concerned some years ago because the ratio of infection in our department was a little bit higher than expected, so we conducted this retrospective review. It was 2011. It's a retrospective analysis. As I said, it included 810 patients, same surgical team, 4 years period, mean age 33.5, mainly males. The results were we had 15 patients, meaning 1.8% of septic arthritis after the reconstruction. 11 were hamstrings, 4 were PTB. In terms of the bacteria, 10 were coagulase negative streptococcus, 2 staphylococcus, 2 were staphylococcus aureus, 1 was a methicillin-resistant staphylococcus, 1 was the former propionibacterium, now Cutibacterium agnes, and was unknown. We treated with progressive lavage, 1 to 3. Initially with intravenous antibiotics for 1 week, and then oral antibiotics up to 6 weeks. In that sense, we were able to heal all the patients but one with graft retention. So in one case, we have to remove the graft. The functional outcomes were good, but not as good with when we compare with the guys that do not have any kind of infection complication. So Lisholm 77 versus 90. IKDC 70.4 versus 86.6, and the Catimil 1000 was not significant difference. So the results were not that bad, but not that good. But the main concern was this 1.8 ratio of infection. So we look at our protocols to infection control. We were applying at that time also the limited hair removal. We never use razors. We always use powered clippers. We encourage our patients to have chlorhexidine bathing, and if not, they do it during or before surgery, immediately before surgery. We're using political antibiotics based on cefazolin, 2 grams before surgery, and in case of allergies, we use vancomycin. And when we look to the most prevalent bacteria in our areas, in 90% of the cases, we saw that they are mainly Staphylococcus, either epidermidis, aureus, or sometimes methicillin-resistant Staphylococcus, and secondarily, very secondarily, Cutibacterium agnes. So if you look at this bacteria and the profile of this antibiotic treatment, we saw that vancomycin is active against all of them. Potentially so active against 90% of the current ACL reconstruction infections. Besides of that, vancomycin is a water-soluble antibiotic, low allergy rate, with is head stable and it has low resistant rates among gram-positive bacteria, and also has been used over time for local antibiotic infusion into joints. So we have this in mind, and then this paper appears. This paper has been done. It's an experimental paper by a group of Australia, led by Chris Bertullo. They experimentally soaked tendons in vancomycin solution. I will tell you afterwards how to do it. And they saw that the amount of release and elution follows a profile that is releasing antibiotic for 24 hours, 2 micrograms per milliliter, depending, of course, the rinsing of the tendon volume, the soak solution used, etc. But in terms of vancomycin elution, toxicity concentration, were lower than previously reported, particularly for osteoblast and chondroblast, and it is always above the minimum inhibitory concentration required for a Staphylococcus. So with that material in hand, we thought in conducting a study to determine whether a graft soaked in vancomycin during the process of harvesting and preservation will reduce the rate of infection following ACL reconstruction. So we did this study. It was prospective case control analysis of ACL reconstruction over an 8-year period. In group 1, the initial 4 years is a retrospective series of this study. The patients were operated on under the classical antibiotic prophylaxis, so a single dose of 2 grams of intravenous cefazolin, and in case of allergy, 500 milligrams of vancomycin. And in group 2, we add to this classical protocol the soaking of the graft in vancomycin during the preservation at the time of harvesting the graft. So the technique was like that. To pre-soak, we just use a solution of 100 milliliters of sterile saline. Then we submerged the graft in this, unwrapped the graft in this solution, and the graft was left here until used for the reconstruction. So the results of our study were 810 patients were in group 1. Classical protocol, 734 in group 2, 15 cases of knee joint infection can be identified, all of them below to group 1. So there were no infections in group 2, the one we used the adding of vancomycin. At practically the same time, the group that did this experimental work, Chris Bertullo, published exactly the same results. Retrospective series analysis in 2012, more than 1,000 patients, group 1 classic antibiotic, group 2 adding Banco wrap, we call that way the technique. In group 1 for postoperative infections, in group 2 no infections at all. Several groups published afterwards, same results. So, in conclusion, autograft pre-soaking in vancomycin in combination with this classical antibiotic protocol reduces the rate of knee infection almost to 0. Not to 0, but almost to 0. But there are, of course, some frequent asked questions like, why is so effective this technique, or does vancomycin may harm the graft, or it is cost effective? Well, we try to respond all these questions by doing this simple prospective study in 15 patients where we harvest samples of hamstrings and we took samples at every single step of harvesting and preparation. So sample 1 was peritendinous tissue at the time of harvesting, sample 2 were tissue graft during preparation or after the preparation, and sample 3 were a piece of tissue we retrieve after doing the vancomycin wrap. And the results were like that. 14 of the cases we found, in 14% of the cases we found some bacterial growing, 7 out of 50, and this is the profile of our bacteria. However, when you look at the sample 1, there are just 2 contaminations, one by Cutibacterium agnes, one by one special Staphylococcus. In sample 2, meaning after harvesting and preparation, there were 5 more contaminations. The most interesting thing is that after the wrapping in vancomycin, all of the contaminations were gone. So all the grafts were negative after vancomycin wrapping. Does it harm the graft, this vancomycin? Well, there are different studies. I don't want, we have some problems with the time, so I don't want to go in detail of that, but these 3 studies were done in comparison. The last one is from our group, and we compare in terms of rupture rate, and there were no differences between the grafts that were preserved with this technique and the grafts that don't. It is cost effective. This was a difficult calculation. We worked together 3 groups, one in Spain, one in Australia, and one in the United States. It's based on a model. It's really well done. It was published by American Journal of Sports Medicine, and what we saw is that the technique is cost effective. However, if the infection rate go lower than 0.014, probably the vancomycin wrap would no longer be necessary, would no longer be effective. So, in conclusion, as this commentary of one of the editors of Arthroscopy said, if you use this technique, the chance of having an infection is 15 times less. So I think nowadays is the gold standard as should be used. I thank you very much for your attention, and I invite you to the next ESCA Congress that should be held in 1.5 years' time in Prague. Thank you very much.